What's good, everyone? Today, I'm gonna talk to you about some information about a certain infection called tuberculosis and some of its related anatomy, specifically in the respiratory system. Now, let's take a close look. The thoracic cavity is a kidney-shaped, transversely ovoid space which is deeply indented posteriorly by the thoracic vertebral column and the heads and necks of the ribs that articulate with it. The cavity is divided into two bilateral pulmonary cavities, with each cavity containing the lungs and pleura, which occupies the majority of the thoracic cavity. In our respiratory system, the lungs are organs of respiration that oxygenate the blood. They are elastic and recoil to approximately one-third their size when the thoracic cavity is opened. The apex of the lung ascends above the level of the first rib into the root of the neck and is covered by cervical pleura, while the base of the lung rests on and accommodates the same dome of the diaphragm. Showing you an X-ray with each lung consisting of apex, which is the blunt superior end, lying above the level of the first rib. The inferior surface, called base, sits on the diaphragm. And the lung margins and pleural margins correspond to midclavicular, mid-axillary, and mid-scapular landmarks. Each lung is invested by and enclosed in a sac called the pleura, consisting of two continuous membranes. The visceral pleura, which invests all surfaces of the lungs forming their shiny outer surface, and the parietal pleura, which lines the pulmonary cavities. Visceral pleura also provides the lungs a smooth surface for frictionless movement and also continues with parietal pleura at the hilum of the lung. The right lung is larger and heavier than the left but is shorter and wider and is divided into superior, middle, and inferior by the oblique and horizontal fissures, with the left into superior and inferior lobes by the oblique fissure. The trachea constitutes the trunk of the tracheobronchial tree and then bifurcates at the level of the sternal angle into main bronchi, passing inferolaterally to enter each lung at the hilum, and divides into secondary lobal bronchi, each supplying a lobe of the lung, and further divide into tertiary segmental bronchi that supply the bronchopulmonary segments. Embryologically, the trachea comes from the laryngotracheal diverticulum with two lateral outpouchings, the primary bronchial buds, and the associated cartilage, connective tissue, and muscles are derived from the splanchnic mesenchyme surrounding the laryngotracheal tube. The embryologic origin of the lungs and bronchi occur in the fourth week, where the primary bronchial buds grow laterally into the pericardio-peritoneal canals, the primordia of the pleural cavities. Up to the 24th week, an approximate of 17 orders of branches have formed, and respiratory bronchioles have developed. An additional 7 orders of airways develop after birth. On the anterior border of the lung are the costal and mediastinal surfaces. The inferior border surrounds the diaphragmatic surface of the lung and separates this surface from the costal and mediastinal surfaces. Lastly, the posterior border is where the costal and mediastinal surfaces meet posteriorly. Lungs are attached to the mediastinum by the roots of the lungs, which consist of the bronchi, pulmonary arteries, superior and inferior pulmonary veins, pulmonary plexuses, and lymphatic vessels. If the lung root is sectioned medial to branching of the main bronchus and pulmonary artery, we have here pulmonary artery, the superior-most on the left, superior and inferior pulmonary veins, anterior-most and inferior-most respectively, and main bronchus against and approximately in the middle of the posterior boundary. A wedge-shaped area on the mediastinal surface of each lung through which the structures forming the root of the lung pass to enter or exit the lung, called the hilum. Each lung has a pulmonary artery supplying blood and 2 pulmonary veins draining it. The right and left pulmonary arteries arise from the pulmonary trunk and carry venous blood to the lungs for oxygenation. A superior and an inferior pulmonary vein on each side carry oxygen-rich blood from corresponding lobes of each lung to the left atrium of the heart. The middle lobe vein is a tributary of the right superior pulmonary vein. The lymphatic vessels originate from superficial subpleural and deep lymphatic plexuses. The inferior lobe of both lungs drain to the inferior tracheobronchial nodes, while the other lobes of each lung drain primarily to the same superior tracheobronchial lymph nodes. From here, the lymph traverses the paratracheal nodes and enters the bronchomediastinal trunks. The innervation of the lungs and visceral pleura is the pulmonary plexus that is located anterior and posterior to the roots of the lungs and has 3 fibers. Parasympathetic fibers constrict the bronchial muscle and pulmonary vessel of the bronchial tree and secretory to the glands of a bronchial tree. Sympathetic fibers dilate the bronchial muscle and pulmonary vessels and inhibit the alveolar glands. And visceral afferent fibers have reflexive function by conducting subconscious sensations associated with reflexes, and pain sensation function by conducting impulses generated in response to painful or injurious stimuli. The innervation of the parietal pleura includes the intercostal nerves that supply the costal pleura and the peripheral part of the diaphragmatic pleura for sensations of touch and pain, and the phrenic nerves that supply the central part of the diaphragmatic pleura and the mediastinal pleura. Now let's get into the clinical side of things. Tuberculosis or TB is a multisystemic infection caused by Mycobacterium tuberculosis, an alcohol and acid-fast bacillus, and an obligate aerobe. It primarily affects the lungs, but can also affect other parts of the body. Primary infection occurs through the inhalation of aerosolized droplets from an infected person containing tubercle bacilli that reach the alveoli of the lungs. TB is a major cause of ill health and one of the leading causes of death worldwide. According to WHO, TB is the second deadliest infectious killer after COVID-19. According to the WHO Global Tuberculosis Report, the Philippines is ranked 4th among the 30 high TB burden countries worldwide, with more than 500 cases per 100,000 population in 2020. It is estimated that in 2020, nearly 4.3 million people fell ill with TB, and an estimated 700,000 died, excluding HIV-TB mortality, because of the disease, which is more than half of global TB deaths, estimated at 1.3 million for the year. In the Philippines, tuberculosis death rate was 28 cases per 100,000 people, according to the World Data Atlas. Geographically, most TB cases were in Southeast Asia, Africa, and the Western Pacific. People with compromised immune systems, such as those living with HIV, cancer, malnutrition, diabetes, or people who use tobacco and alcohol, have a higher risk of falling ill. The use of immunosuppressive agents such as long-term corticosteroid therapy has also been associated with an increased risk. Young adults have the highest rates of active TB globally, but in developed countries, older individuals experience the highest rates of disease. Clinically, tuberculosis falls under 2 important types, primary and secondary. In primary TB, the onset of first infection, though most cases are asymptomatic. The inhaled bacilli implants in the distal air spaces of the lower part of the upper lobe, or the upper part of the lower lobe, usually close to the pleura. It lacks marked tissue damage or cavitation. As sensitization develops, a 1 to 1.5 cm area of gray-white inflammation with consolidation emerges, known as a gun focus. TB also gets to bronchopulmonary or hilar lymph nodes, either carried over by immune cells through the lymph or by direct extension of the gun focus infection, which also often caseate. Together, this caseating tissue and associated lymph nodes can make up the characteristic gun complex. In some cases of infection, the gun focus enters a state of latency. This state is known as latent tuberculosis, which remains dormant and viable. In secondary TB, reactivation of latent tuberculosis infection has occurred due to old age or immunosuppression. The lesions of secondary TB classically involve the apex of the upper lobes of one or both lungs, wherein concentration of oxygenation is at its greatest and there is presence of cavitation. Let's have an 18-year-old male as our patient for today. We'll call him Tommy. Tommy presents with a 2 to 3 month cough that may be caused by the mycobacterial product of TB irritating the cough receptors of the upper airways and cardiac and esophageal branches from the diaphragm. This is then processed by the medulla and finally inducing cough through the action of diaphragm, abdominal wall, and muscles. Hemoptysis is due to apical lesions induced by TB bacteria expanding into the adjacent lung, eventually eroding into bronchi and vessels. The inflammatory response in TB results in increased toxins and cytokines resulting in fevers and night sweats, and a decrease in leptin production with malabsorption may explain the 15-pound unintentional weight loss. He said that he started to feel mild shortness of breath with activity following his return from the mall. He doesn't vape nor smoke, and he did point out that his maternal grandmother had pulmonary tuberculosis 2 years ago. And since that time, he has traveled extensively, including Europe and Asia. Tommy's physical examination showed decreased breath sounds and coarse crackles in the right lower lung field. This happened due to a decreased ventilation from the buildup of fluid in the visceral and parietal pleura of the lungs. Meanwhile, coarse crackles in tuberculosis are produced due to an explosive opening of collapsed airways in the large bronchi or in the bronchiectatic segments closed by secretions such as blood, thus inducing a rapid equalization of gas pressure in the lungs. His laboratory study showed fungal culture with negative endemic fungi, negative ELISA test for HIV acid-fast staining of sputum smear with 4+ acid-fast bacilli, TB PCR assay and commercial TB PCR assay with positive with Mycobacterium tuberculosis, confirming a diagnosis of tuberculosis in our patient. Here are some advice to do if you suspect or are diagnosed with TB. 2 weeks cough? Consult your doctor immediately. Wear a mask to prevent bacteria from spreading. Never skip medications. A relapse of TB becomes more dangerous. Wash your hands before and after having meals and keep a sanitizer handy. Avoid overcrowded places to reduce incidences of TB. Spread love, not TB.